And then last chapter of the semester, we have chapter 29, which is drug therapy for female reproductive problems. So some background on the female reproductive system. Conception is when a mature ovum is released from a woman's ovary and fertilized by a sperm during sexual intercourse. When the fertilized egg successfully implants in the uterus, the condition of pregnancy results and an infant can be born 9 months later. Menstruation is periodic shedding of uterine lining that is the result of cyclic changes of the female hormone levels. The maturation of the egg and proper preparation of the uterine lining support pregnancy, but if we don't have a fertilized egg, then we shed and have menstruation. Menarche is the beginning of menstruation years in adolescent females. Estrogen is the main female sex hormone that's secreted by ovaries and the adrenal glands. And menopause is the cessation or stopping of menstrual periods and ovulation. It occurs naturally as a result of age or as a process of involution gradually occurs. Perimenopause is the transition from regular hormone cycles to the time when menstrual periods have stopped for a full year. And it involves decreased levels of estrogen. During this time, the hormone levels change, causing the woman to have a variety of uncomfortable but usually minor symptoms. We use hormone replacement therapy to replace the naturally secreted estrogen and progesterone with exogenous hormones during the perimenopausal period. These increase blood estrogen levels, which helps with perimenopausal symptoms by relieving the direct problems from low estrogen levels, which are listed in the box on page, let me see here, 524. As well as inhibiting the feedback system and lowering the levels of follicle stimulating hormone, reducing the side effects of high FSH, also listed in that box. So the intended response is to reduce things like hot flashes and night sweats and vaginal dryness, as well as improving the quality of sleep. Side effects include breast tenderness, breakthrough bleeding, fluid retention, weight gain, and acne. And there's a box that lists these different hormone replacement therapy drugs or HRT drugs on page 523. Side effects, like I said, or like I listed, occur with conjugated estrogen alone and when combined with progesterone. So either way, if it's by itself or when it's combined, you'll still see these side effects. Adverse effects, these people or these women are at more risk for heart attack, blood clotting, excessive uterine bleeding, increased cancer growth, liver impairment, gallbladder disease, and pancreatitis. We teach our patients to avoid nicotine, check weekly for liver issues like jaundice, and report chest pain, difficulty breathing, or symptoms of a stroke. The hormones in perimenopausal hormone replacement therapy can increase the growth of cancers that are hormone sensitive, like cervical, breast, ovarian, and uterine cancers. So these drugs should not be used in women who have a history of these types of cancer. Emphasize to your patients that prescribed hormone replacement therapy or with prescribed hormone replacement therapy to avoid nicotine in any form, including smoking, vaping, patches, or gum. We'll also talk about contraception. This is the intentional prevention of pregnancy. The different forms of contraception include abstinence, surgery, barrier methods, spermicidal foams and gels, intrauterine devices, and hormonal contraception. In this class, we're going to focus on the hormonal contraception. Hormonal contraceptives use hormones to suppress ovulation and prevent pregnancy. They interfere with the body's natural production of estrogen and progesterone by turning off tissues in a pathway that causes negative feedback, that uses negative feedback. These can be taken orally, used as topical applications like transdermal patches, uterine rings, or they can be released by a device directly in the uterus, implanted under the skin, or injected parenterally. Oral contraceptives are the most common. The most effective oral contraceptives contain two types of hormones, a synthetic estrogen and a synthetic type of progesterone known as progestin. But some called mini pills only contain progestin. The intended response here is suppression of the ovum, maturation, resulting in no ovulation and no conception. Side effects include breast enlargement and tenderness, nausea, fluid retention, weight gain, breakthrough bleeding. The severity of side effects is related to the dosage of the specific hormones used for contraception. Some women have more acne while taking oral contraceptives, and others have less acne. It just depends on the person. Adverse effects include risk for blood clots, hypertension, liver toxicity, increased growth of certain cancers. Oral contraceptives require a full cycle before they're effective, so it's important to teach our patients that. Teach these women to use an additional method of birth control during that first cycle. Scheduling is important for best effectiveness, and they should know this as well. They should be taken with food at the same time every day. I don't want my patient to take more than 1 pill per day. If a dose is missed, it should be okay, but if 2 or more are missed, then they need to start using a different method of contraception for the rest of the cycle. No smoking or nicotine for any of these patients. That increases the risk for blood clots. These can cause a lot of drug interactions, so it's important to talk to the provider about other drugs that the patient's taking and to let the prescribers know that they're taking oral contraceptives as well. Remind women that although hormonal contraceptives protect against pregnancy, they provide no protection against HIV and other sexually transmitted diseases. These are not approved for children before puberty. Early chronic exposure can cause the growth of the long bones to stop. They should not be taken during pregnancy. They are also present in the breast milk and have had adverse effects on the infant, so they shouldn't be taken while breastfeeding either. And then we'll talk about osteoporosis. I believe that we talked about osteoporosis and musculoskeletal, but we're just going to go over it again here. So the bones have to stay firm and dense to be strong enough to provide support to the body. Throughout life, new bone cells are made with osteoblast activity, and old bone cells are removed with osteoclast activity. Mature bone cells are called osteocytes. In infancy, childhood, and adolescence, osteoblast activity occurs at a fast rate. In adulthood, the osteoblast activity and osteoclast activity should be balanced. As a person ages, osteoblast activity can slow down. Osteoclast activity also causes bones to lose minerals, especially calcium, which is a process known as bone resorption of calcium. This results in the bones becoming longer as the individual grows taller and becoming more dense to support the body structures as the individual grows heavier. In addition to bone cells, minerals such as calcium and phosphorus deposit and form a matrix within the bone to add density and strength. If osteoclast activity then continues at a normal rate or a faster rate, bone formation becomes unbalanced with bone removal, occurring faster than bone replacement. So we have osteopenia, which is an imbalance in the bone metabolism that leads to osteoporosis. The main problem here is the increased risk for a fracture. When osteopenia becomes more severe and bone density is lost, osteoporosis is present. Risk factors are small stature, family history, daily corticosteroid use, low levels of androgens and estrogens, and limited weight-bearing activity. A variety of different drugs and supplements are used to manage or slow the progression of osteoporosis, including bisphosphonates, estrogen agonists, antagonists, and biologics. So with the bisphosphonates, the intended response is for osteopenia to progression to be slowed or stopped, the density and strength of the bones to be maintained, and normal levels of blood calcium. Side effects of bisphosphonates are abdominal pain, headache, esophageal reflux, and nausea. The estrogen agonist and antagonist side effects are muscle spasms, nausea, indigestion, and weight gain. The biologics side effects are skin rashes and musculoskeletal pain, and the parathyroid hormone agonist side effects are nausea, gastric distress, and constipation. Adverse effects include jawbone osteonecrosis. Teach your patients that, estrogen receptor agonist, antagonist adverse effects are increased risk for clot formation and gallbladder disease. Biologic adverse effects are increased risk for severe allergic reactions and possible anaphylaxis. The risk for atypical bone fractures is increased with romosozumab. And then, let's see. Sorry, looking through my notes. Parathyroid hormone agonists can cause elevated blood calcium levels and increase the risk for bone cancers and kidney stone formation. Assess the patient for an allergic reaction during and after subcutaneous injections of any of the biologics and keep emergency equipment in the room with the patient. Patients should inform their dentist or oral surgeon that they're taking bisphosphonates, and do not use nicotine in any form with raloxifene. Teach our patients that take oral bisphosphonates to take them early in the morning after breakfast and to remain upright for 30 minutes after they take them, and to ensure patients that patients understand the administration schedule and technique for different second-line drugs, and to be aware of any side effects or adverse effects and call the provider if new symptoms appear. And let's see. You can see these drugs on page 528, 529, and 530. And then that is it for our female reproductive problems, and that is it for lecture and content for class this semester.